Thank you very much, Dr. Alexander, for kind introduction. The theme of my presentation today would be how to avoid side effects in orthodontics. Do we have a visual? Okay. These are side effects that we frequently observe in daily practice. Most of them are tooth movement in undesirable direction, both in active and reactive part of the arch. Suppose we would like to retract a canine, not only distal force, but there is always reciprocal mesial force acting on the posterior teeth. No matter how cleverly we design the appliance, we cannot overcome the law of nature. If we call the retraction force on the canine the main effect, then the reciprocal mesial force on the molar can be called side effect. Particularly, it is called adverse side effect if this mesial force on the molar is not what we want. On the other hand, if this mesial force is desirable, then it is called beneficial side effect. Therefore, side effects are not always undesirable, and it could be either good or bad, depending on situations. Therefore, I would like to talk about both good and bad aspects of side effects. Side effects can be subcategorized into two groups. These side effects are acting on the reactive units, commonly known as side effects on the anchorage unit. And these side effects are observed in the active units. The most common side effect is from reciprocal forces. Here we have an anterior diastema, and a simple elastic would produce equal and opposite forces. Both main effect and reciprocal side effects are beneficial for the patient. No one would treat the patient like this, but let's suppose we engage an elastic like this to close the space sequentially in two stages. First, we engage the elastic on the right side to close the space. The force on the central is good, but the force on the lateral would be bad. Then we move the elastic to the left side to close the remaining space. The anterior diastema was successfully closed, but there are undesirable side effects on the laterals that we made during the course of treatment, which is totally unnecessary. You will get the space closed with a huge adverse side effects. Therefore, you should put more efforts on considering side effects than main effects. Laterals are rotated, and we know that rotation control by lingual bracket is very difficult because bracket width is small. Rather than rotation control by tight ligature, simple elastic will produce equal and opposite force and easily correct the rotation. Both premolar and molar are rotated in correct direction by simple elastic on lingual side. If continuous labial arch wire was used, there should be many adverse side effects. Open coil spring will not only open up the space, but also derotate premolar and molar at the same time. In other words, all of the side effects of the force and moments are working in correct direction in this case. Here we have a famous Dr. Burstone's three-piece intrusion arch. The main effect would be intrusion of incisor, and side effects are tip back and extrusion of posterior reactive unit. Are side effects in the posterior reactive unit good or bad? Well, it depends. What is required in this patient is correction of deep overbite and class 2 molar relationship. The intrusion of spring produced not only intrusion of the incisors, but extrusion of posterior teeth and tip back of upper molar as a side effect, and it would be beneficial in this patient. Here we have a badly rotated molar. The simplest method would be applying equal and opposite force by two elastics. The molar would rotate in correct direction by couple, and this movement is what we want. However, not only molar rotates, but adjacent premolar and second molar will rotate at the same time, which might be undesirable. Therefore, applying couple using two elastics are not indicated in this case. For correction of badly rotated single tooth, a better solution would be using lingual arch rather than equal and opposite force pitted against adjacent teeth. A bracket was placed in unusual manner, however. It doesn't matter to apply a couple. As we activate the lingual arch like this, large moment would be produced on the target tooth with very little mesiodistal forces because moment arm is very long. Perhaps the distance between molar across the arch would be the largest interbracket distance that we can get in the oral cavity. Notice that there is no apparent side effects during the rotation of single tooth more than 100 degrees. Let's take a look how side effects are produced by continuous full arch wire. For example, in a typical extraction case, full arch wire was inserted prior to retraction for leveling. And space was closed. Let's suppose the arch wire was not rigid enough so that the teeth tipped into the extraction site. Perhaps sequential changing of wire by increasing the stiffness will move the roots together, and this would be the best case scenario we can expect. It will not happen in the real world, but what if these teeth are enclosed right after the space closure? Just a thought experiment. Sequential changing of wire will result in some kind of situation like this, and of course, you don't want to have results like this. In the real world, best case scenario never happens as much as worst case scenario can happen. Generally, we observe the gentle reverse curve of speed in between the best and the worst case scenario, somewhat like this. As lower cuspid tips into the extraction site, a curve of speed was produced and lower incisor was erupted. In this case, as we have curve of speed, we might think a reverse curve of speed will flatten the occlusal plane. But generally, the force system produced from continuous reverse curve is not desirable in many times. What we need is a local equal and opposite couple only in between these two teeth. Lower second premolar was extracted and space was closed. However, still root movement is required. Localized V-bend was placed between molar and premolar only instead of general reverse curve in a full arch wire. Or just a small piece of wire is used instead of continuous full arch wire. This segment of wire produced desirable force system only in between two teeth without any side effects. Here we have a badly rotated centrals. Looking at the frontal view, we can clearly see the spacing and rotation in the region of centrals only. Segment of wire between central was used instead of continuous full arch wire. There will be no side effects at all to rotate the both centrals using only segment of wire. One of the most challenging treatment would be correction of midline in orthodontic field. The most common approach to correct the midline is to take a patient and treat them with the anterior crisscross elastics. However, we would find that our success would be somewhat limited. It is our contention that the use of these intermaxillary mechanics with elastic will create more problem than they solve. Although the midline is moving over a durable manner, we should notice that the occlusal plane canting is produced in the frontal view as an inevitable side effect. As we've learned from previous lecture, certainly the use of anterior crisscross elastic is not the method of choice for correction of midline. Therefore, we use couple instead. Single force at the crown or couple are totally different physical quantity. Even the units of each are different, but apparent tooth movement are very similar to each other. Hence, a couple can be used instead of a single force at the crown. In this case, midline discrepancy is from individual simple tipping of upper and lower incisors. In the upper, incisors lean to the left side. The lower incisor lean to the right side. Notice that there is no apical base discrepancy. Straight wire on the angulated brackets produce couples on each incisor with negligible amount of vertical forces. So that individual rotation around the center of resistance can correct the midline without any horizontal forces. Here we have a patient with severe midline inadequacy. PA head film shows that a midline problem is due to tipping of incisors, but upper and lower apical bases are relatively symmetrical. Panoramic view of initial and during the treatment. Here's the end of the treatment. Symmetric extraction and not any asymmetric mechanic was used in this case. Midline was corrected without any horizontal forces, and occlusal plane canting was not produced. I'm certainly not saying that there is no indication for use of anterior crisscross elastics. Selectively, sometimes we must have horizontal movement and rotation of one arch in respect to another arch. What if the midline is off and occlusal plane is rotated like this in the frontal view? The forces from anterior crisscross elastic will correct the midline and alter the plane of occlusion at the same time. The main effect and side effects are both beneficial for this patient. Let's take a look at this patient with a gross discrepancy skeletally with local midline problem. And we can appreciate after we look at the patient also shows asymmetries with canting of occlusal plane to begin with. This is trimmed model, but this would not be correctly representing the cant of occlusal plane. We could take the model in our hands and rotate them. so that the model should be trimmed somewhat like this to visualize occlusal plane canting. The anterior criss-cross elastic corrected the midline, and accompanied side effects corrected the canting of occlusal plane at the same time. Once again, we should think not only main effects, but also side effects all the time in 3 dimensions. Same phenomena happens in lateral view. As the forces are acting away from the center of resistance, rotation or steepening of occlusal plane is produced as a side effect. Let's take a look at a patient with class 3 relationship. Upper and lower bicuspid were extracted, and class 3 elastics were used to correct the class 3. Superposition shows horizontal tooth movement of the teeth. And also notice that side effects of the occlusal plane rotation, which was desirable in this case. Therefore, you should understand not only main effect of the appliance, but all the side effects of the appliance at the same time. There are also side effects in occlusal view, especially in correction of asymmetric occlusion. Let's take a look what happens in anterior criss-cross elastic or intermaxillary elastic in occlusal view. If anterior criss-cross elastic was used and suppose large friction between brackets and wire inhibits individual movement of each tooth along the arch wire, there is a rotation of whole dental arch so that a symmetric overjet will be created by anterior criss-cross elastic. Or if class 2 and class 3 intermaxillary elastics were used, posterior crossbite will be produced. This is not only true with the use of bilateral class 2, class 3 elastic, that we get this undesirable skewing, but we can also see this with unilateral intermaxillary elastics. In reality, the nature of most of these problems is not to skew the entire arch, but rather to move the teeth along the line of arch like the pearl on a chain. In correction of asymmetries, mesial forces on one side and distal force on the other side is not possible, because of the force system is not in equilibrium. Instead, we can use equal and opposite couples. This patient shows differential molar relationship, class 1 on right side and class 2 on left side. If we take a look at the patient's panoramic view, upper left buccal segment has been tipped to the mesial side. So that the location of center of resistance is relatively symmetrical. That means only a couple is necessary to correct the molar relationship, not distal force. Therefore, unilateral tip back and unilateral tip forward mechanic of lingual arch was used. This is the force system from lingual arch in the palatal side, which is not shown in this slide. In the buccal side, bilateral tip-back spring was used to cancel the unwanted mesial tipping moment on the right side, so that only left molar is tipped distally. Once again, the type of tooth movement that is indicated is usually movement along the arch rather than to skewing of entire arch. Posterior crossbite correction is very challenging due to many side effects. Commonly used posterior criss-cross elastic can correct the posterior crossbite. but it needs patient cooperation, and most significant side effects are vertical component of forces, which produce open bite tendency. Let's take a look when labial arch wire was used to correct the posterior crossbite. I think we realize in many cases we use this type of appliance. This is a force system from straight wire connecting the first and second molar with step relationship. In other words, it's called class 1 geometry. To obtain lingual force on the second molar, there are too many side effects we should sacrifice, such as labial force on the first molar and accompanied undesirable moments. They are all adverse side effects. After the leveling, posterior crossbite may look successfully treated. However, in lateral view, localized crossbite became generalized malocclusion due to unwanted side effect by inadvertent leveling with straight wire. Perhaps this would be more difficult to treat. What would be the best force system for correction of this bilateral crossbite? As we need only single force on the second molar, direct application of single elastic or coil spring would be the appliance of choice for this patient. But it would be very uncomfortable for the patient. Instead, same force system was applied using passive TPA, and separate elastics were used for patient comfort. The force system of separate elastic looks from the occlusal view is exactly the same as the one with single elastic across the arch. Notice that there is no adverse side effects. Let's consider another method in correction of unilateral crossbite. Asymmetric application of active lingual arch is used to produce couple on one side only. This patient shows unilateral crossbite caused by lingual inclination of lower molar on the left side. Unilateral expansion was produced by asymmetric application of lingual arch. Notice that no side effects were observed on the right side. This patient needs unilateral constriction on the lower right molar. Unilateral constriction was produced using a couple from active lingual arch with no apparent side effects. One of the etiology of occlusal plane canting is iatrogenic side effects that we make during the treatment. Segmental leveling of anterior segment of high canine produce unexpected occlusal plane canting. In this case, high canine leveling with continuous arch wire produce lateral open bite with canting of occlusal plane. If you don't find a proper place to eliminate side effects desirably, then the stress is uniformly distributed along the rest of the arch. To avoid canting of occlusal plane, stabilizing the rest of the arch with rigid wire and overlay wire is indicated. The cant of occlusal plane was maintained by rigid stabilizing arch wire. The best solution would be just open up the space and wait for spontaneous eruption. I have done nothing but to open up the space and kept waiting. High canine was erupted spontaneously without any vertical forces. For active correction of occlusal plane canting, off-center asymmetric application of intrusion spring is useful. or combination of intrusion and extrusion arch can be used for canting correction. Now, let's consider side effects on the active unit by associated moments. Retraction force is applied at the labial side. The yellow arrows are equivalent force system at the center of resistance of the canine. The force and the moment are both acting in desirable direction and there is no adverse side effects. This is called consistent force system. On the other hand, if the canine is rotated in opposite direction like this, the direction of force produced is correct, but the moment is operating in undesirable direction, and this is called inconsistent force system. If we change the direction of force to eliminate inconsistency, the moment might work in correct direction, but the force is working in wrong direction. That means inconsistency cannot be eliminated by application of single force on the labial side. In this case, the point of application is moved over the center of resistance and placed on the lingual side. Now, both force and moments are working in correct, desirable direction, and the force system becomes consistent. This is frequently found situation when the first molar is lost. In this case, a cantilever tip-back spring produced both tip-back moment and extrusive force at the same time. Both are desirable, so this cantilever spring produced consistent force system. After retraction of canine by controlled tipping, root movement is required. The distally extended cantilever canine root spring produced correct direction of moment and force. If continuous arch wire was used for root movement, there should have been many side effects. Let's take a look at a similar but little bit different case. Will tip-back spring consistent in this case? The direction of moment is correct or desirable, but the extrusive force on the molar will make the situation worse if patient is open by tendency. Therefore, in this case, cantilever spring is not indicated because it is inconsistent. To overcome inconsistency, the point of force application is moved across the center of resistance. And this becomes consistent force system. But there is no place to engage the hook of the cantilever in empty space posteriorly. Therefore, we can use distal extension to make consistent force system. In this case, a single force was applied distal to the center of resistance of the molar. Distal intrusive force was replaced with the equivalent force system at the center of resistance. It is clear that the whole of the force system is working in desirable direction. There will be no adverse side effects at all in this case. When using a segmental wire, proper location of wire cut is very important for consistency. If the wire was cut between the centrioles, the force system is consistent. However, if the cut was made between central and lateral, the force system is inconsistent because the force is working in wrong direction. Where would you cut the wire for this patient? Yes, cutting the wire between centrals and distal extension of the wire makes the force system consistent. Cantilever overlay spring was extended distally for consistency. Both clockwise moment and extrusive force are desirable for this patient. Perhaps continuous full arch wire leveling might have produced altering of occlusal plane. As we have seen, a straight wire does not always produce consistent force system. Because force and moments are associated in constant direction in straight wire. Unnecessary rotation will be produced by associated moment of activated straight wire. A loop can be used to eliminate this inconsistency, such as rectangular loop can dissociate moments from the force so that single force can be produced. And this loop is very useful because it operates in 3 dimensions. It is used for bodily intrusion of canine vertically, or translation of tooth in lateral direction without any rotation in occlusal view. So-called strategic extraction is used instead of TADS to eliminate side effects. All of the side effects are concentrated to a tooth and extracted later. This is an extraction case with first premolar to be extracted. Before extraction, premolar was used as an absolute reactive unit. All of the side effects, such as tip-back moment and extrusion force, are concentrated on this tooth. After intrusion of incisor, this tooth is extracted. Severe rotation of molar is corrected using cantilever spring pitted against the first premolar, which is to be extracted later. After proper rotation and lingual movement of molar was produced, first bile was extracted, and symmetric space closure was performed as usual manner. Here is another case with unilateral posterior crossbite. Upper left is leaning to the buccal, and the lower left is leaning to the lingual. In the upper, equal and opposite couple was applied by twisting of small piece of rectangular nine-tie wire. Notice that the second molar is tipping to the lingual, and the first premolar is tipping to the labial side. And same mechanic was used for the lower. The lower second molar is tipping to the buccal side. All of the side effects were concentrated on the first premolar, and they were extracted after correction of posterior crossbite. Therefore, there is no side effects, or I could say all of the side effects were eliminated. Lastly, primary tooth is also used as an absolute anchorage. More than 90-degree rotation of central was produced pitted against primary tooth. Only 2 brackets and small piece of cantilever TMA wire was used. In adult patients, many prolonged retention of primary teeth are ankylosed, and it serves as very good reactive unit. In occlusal view, to rotate the incisor, retained primary molar was used. The incisor was successfully rotated using primary tooth as a reactive unit. We have briefly reviewed how to avoid side effects. Remember, side effects are not always undesirable. To utilize these side effects, we should establish a specific goal where tooth to be moved. And of course, we should exactly understand all of the biomechanic force system produced by an appliance in 3 dimensions. Thank you very much.